ask my co-chair, Dr. Anuraag, to introduce the next speaker. Over to you, Anuraag.
The next part is managing IBD-associated opportunistic infections and cardiovascular risk. The speaker is Dr. KT Shenoy, who is a professor and head of Department of Gastroenterology, SGMC Medical College, Kerala. Over to you, sir.
Can I ask the organizers to share my slides? Okay, thank you very much, Dr. Vishal and the Takeda for inviting me to speak on managing IBD-associated opportunistic infections. Myself, Dr. KT Shenoy. Can I get the next slide? I don't have any conflict of interest except that I have got into an agreement with the Takeda for this presentation. Next one. Next. What I will be discussing over the next 20 minutes will be evolving on the IBD treatment strategies and their associated risk. Conventional therapies such as mesalamine, corticosteroids, immunomodulators, small molecules, and of late, the biologic agents have been widely used in the treatment of inflammatory bowel disease. We know how to manage the drug in terms of evaluating the efficacy and some of the endpoints of treatment, such as treat to target. What I am going to discuss today is from the safety point of view, and especially with the GI infections and cardiovascular risk. Next one. We are very clear about the pathophysiology of the disease, starting from the normal gut to the gut which is injured because of ulcerative colitis. In ulcerative colitis as well as Crohn's disease, there are disturbances occurring in the microbiota, which we call as dysbiosis, which triggers off a host of inflammatory responses, leading finally to the disease of ulcerative colitis or the Crohn's disease, depending upon which of these pathways are activated. Next one. Last 25 years, we have been witnessing a number of advances in the therapeutic armamentarium. When I started my career way back in 1979 as a gastroenterologist and getting my training for DM in gastroenterology, we had only salazopyrin and steroids with us. And most of our research has been based on the studies by Truelove and Witz and Azad Khan from UK, who have stabilized the dose of salazopyrin, and they have given us what is the maintenance dose of steroids, as well as how to reduce the dose of steroids, how to initiate salazopyrin therapy, and how to maintain it. This slide shows you the advances which have taken place over the last 20 plus years, starting from the infliximab, the first biologics, followed by the humanized biologic, which is the adalimumab. And now we have a host of biologics, starting with the vedolizumab, both for UC and CD. And then we have the new molecules which have come, and we are likely to have at least 10 molecules over the next 10 years. We have to see the adverse reactions and whether they will get a clearance from FDA in terms of their efficacy and the safety. Next one. The patient preferences and values are extremely important. Currently, we are in an era where we have what we call as the informed choice. When I was a young student in gastroenterology, we give the treatment and patient agrees to take the treatment. But now, the patients are very technically savvy. They have a good amount of knowledge base, both from the Google professor and others, and they come with a lot of questions the moment they know that they have an ulcerative colitis or a Crohn's disease. So these questions are related to the efficacy of the drug and the safety of the drug. Efficacy is one side of the coin and the safety the other side of the coin. We have to have a good balance of efficacy, vice versa safety. The efficacy is the ease of administration, the long-term remissions, and whether they are to be dependent on steroids or other co-medications. Whereas the safety issue stems from the various adverse events related to the human host in terms of infections, marrow suppression, as well as other adverse events such as long-term development of malignancy and other complications. What we will be discussing in the next 15 minutes are mainly from the point of safety in relation to GI infections and the cardiovascular effects. Next slide, please. The immune suppression is the root cause of all the problems of adverse events. We can classify them into three types of adverse events. One which are related to the immune suppression, one which are not only related to immune suppression, they are class related. And the first one is the one which is related to the infections. And these infections are in the form of various infections which can happen in the body. And we can classify them as chronic infections or infections which are the more like opportunistic infections. And we have to really see what are the infections which are related to IBD. Most of them are related to abscesses in the intestine, and they are in the Crohn's disease, or they are related to malnutrition, because this condition is a condition with malnutrition, both malabsorption and maldigestion. The cancers are related to chronic inflammation, colorectal cancers, small bowel adenocarcinoma related to some of the drugs which are used on a long-term basis. The cardiovascular events are related to inflammation or surgery for IBD. And one such cardiovascular event is the venous thrombosis and the episodes of emboli or acute arterial ischemia. The risks which are related to immune suppression are the ones which cause the infections or lymphoma, whereas the class reactions are related to the type of drugs, bone marrow suppression, interstitial pneumonitis, and leukoencephalopathy, which has been described with the anti-TNF drug. Next slide, please. Now let us come to the safety of the biologic agents. All the safety studies are related in the literature to the registries, which are on a long-term basis, continuous feedback to the organizers. But here, I don't see a lot of registries which are in operation, except we have the clinical trials, which are the cohort studies, or a head-to-head comparison between two groups of drugs, or the real-world studies after the drug is in the market. And finally, the meta-analysis or the systematic review or the network meta-analysis. Next slide, please. Now let me come to the first point, which is the cohort studies. Next one. The cohort studies are one of the most important studies to evaluate the safety of the drug. The study which has been projected on the screen is one of the pivotal studies in 2016, which is called as the Victory cohort, which is the study based on vedolizumab in a CD. There were 3.5 infections per 1,000 infusions. Look at the right side of this slide, where we have the events as well as the event rates. The most important events are the enteric infections, 5 per 1,000 patient years of follow-up, which means 10 patients for 10 years, or 1 patient for 100 years, or 100 patients for 1 year is what we call as the 100 patient follow-up years. The second is the sinopulmonary infections, 4.4 per 100. And the third one is the arthralgia, followed by the least common is the septic shock, 0.5 per 100 person years of follow-up. Come to the next slide, please. The next slide gives you a great opportunity which has come in the last 2 years. What is the effect of COVID-19 on the behavior of IBD? Or what does IBD and COVID-19 together will do? This slide shows you the proportion of patients who have been either on ventilator or they died. This is based on a large multi-centric, multi-country study, which is called as the Secure Registry. And this is May 2020. You can see the proportion of patients who needed ICU. The largest one are with oral steroids, and the least one is IL-12 and IL-23 inhibitors, and others are in between. Nevertheless, say that they require control in the ventilator or requiring ICU, which means the course of the disease of inflammatory bowel disease in the presence of a COVID-19 gets aggravated. I had only one patient among my COVID and inflammatory bowel disease. This was a patient on vedolizumab who developed a severe COVID, required hospitalization and ventilation for 12 days. Finally, she came out of the infection and she is pretty good, and we have restarted her on vedolizumab. Next slide, please. The head-to-head studies are the ones which we are going to discuss now. Next one. These are the various studies again with vedolizumab, which is the VARSITY study. The primary endpoints are the clinical remissions, and the second endpoints are the mucosal healing or corticosteroid-free remissions, in addition to safety and adverse events. Let me go to the next one, please. So here, 38.1% had to discontinue the drug. The lack of efficacy was seen in 55.8%. There was no significant loss to follow-up. The discontinuation between the vedolizumab was 24.9% compared to 38.1% in the adalimumab group, which shows that the vedolizumab is definitely behaving better in terms of the discontinuation status. The lack of efficacy was 55% in the adali group compared to only 42% in the vedolizumab. Next one, please. Coming to the safety profile, any adverse events are 69 and 62% respectively. Serious adverse events are 13 and 11%. They are not much different. There was only one death in the vedolizumab group compared to none in the adalimumab group. Next one. Unexpected results. Exposure and adjusted to adverse events. Infections and infestations. In the adali group, it was 43.5 compared to 33.5. These are the incidence rates per 100 patient years of follow-up. Herpes infection 5.3 versus 0.6. Upper respiratory tract infections 22.8 versus 17.9. Arthralgia was not much different. Psoriasis, a very important thing. 2.1 in the adali group compared to 1. There was about a 7.7-fold difference in the psoriasis. We have to see whether this is related to the class of the drug or this is only one of the concomitant features. I think larger studies are needed. Next one. Coming to the real world studies. Next one, please. The real world data is something very, very important. When we look at the adverse events, the patient preferences, physician preference, drug efficacy, and how long the patient remains in remission, because the patients will have not only the disease, they will have comorbidities which may adversely affect the disease progression or the activity of the drug. Next one, please. So this is in relation to persistence of inflammatory bowel disease. An ideal medication should have a high efficacy low adverse effects and highly preferred compared to the other two class of drugs, the anti-inflammatory TNF, high efficacy, immunogenicity, less of side effects, and higher preference. The thiopurines, the non-adherence to therapy, lower efficacy, and adverse events, they all lead to persistence in the inflammatory bowel disease. Next one. In terms of, next slide, please. In terms of biologic agents in moderate to severe ulcerative colitis, this slide shows you the efficacy of three classes of drugs, vedolizumab, infliximab, and adalimumab. Kindly note the survival or the persistence use time. Vedolizumab, the people are able to continue for a longer period of time. And the year one, the persistence is 73% and 45% at year 3. Compared to the adalimumab, it was 61 and 34. The median survival with a 95% confidence limits in infliximab is 15.9 to 27.5. The summary is that vedolizumab persistently are utilized in a significantly higher proportion than infliximab and adali in ulcerative colitis. Next slide, please. Now, these are the group of studies which we call as the network meta-analysis. A network meta-analysis is actually a computation database where we can try to find out the efficacy and the safety of the drug. Next slide, please. This is the network analysis on adverse events in ulcerative colitis. Kindly note that I think, can we go for the, just a minute. Have you gone one slide down? You can go one slide up. One slide up. Okay, now it's okay. So what is the relative risk in terms of direct comparison of the adverse events? Infliximab compared with the placebo, 1.07. The confidence limits are 1.01 to 1.14. It is significant to the extent of less than 5%, 0.03. The first one is FMG, not significantly different compared to placebo. Vedolizumab versus placebo is a 0.86, not significant difference. Next slide, please. This is in terms of the indirect comparisons of the adverse events between FMG, infliximab, adali, and other drugs. The vedolizumab, in comparison with the infliximab, you can see that it is 0.78. This is the adverse events, and the confidence limits are 0.6 to 0.9, which means the adverse events are less in the vedolizumab compared to infliximab. Next slide, please. My previous speaker has spoken about some of the adverse events. Corticosteroids are the mainstay of therapy. These are the drugs when we start with moderate to severe ulcerative colitis, but we don't keep them for a longer period of time because of the adverse events. The next slide, please. The TREAT registry is one of the registries where we looked at the risk factors for serious infections. The first panel shows the univariate analysis with infliximab, serious reactions. It is 1.69 per 100 patient years of follow-up. In the multivariate analysis, these are the hazard ratios. Anything less than 1 is protective, anything more than 1 is adverse events. Infliximab, it is 1.48 times. Prednisolone, it is 1.97 times. Narcotics, it is 2.33, and the CD severity is 2.44. So infliximab and steroid use are relatively having a higher risk of serious infections when the risk is about 2.47 and the 95% confidence limits are highly significant to the extent of 1 per 1,000. Next one, please. The safety implications for thiopurines: hypersensitivity, infections, mostly pneumococcal, meningococcal. So you have to see that most of them should get vaccinated. Myelosuppression, you have to see the blood counts. Lymphoma is one of the adverse events. And in my career of 40 years of gastroenterology, I have seen only 2 cases of lymphoma, and I must have treated more than a few thousands of patients with IBD. Melanoma, non-melanoma skin cancer, I have not seen. Pancreatitis, definitely I have seen a large number. I may not have seen 4%, maybe 1 to 2%. And that is a big problem because you have to think of any other alternative drug. GI intolerance is 8%, probably the highest in terms of safety. Next one, please. So the management of side effects related to thiopurines. Whenever there is a pancreatitis or a flu-like syndrome or myalgia, the first is stop the thiopurine, switch over to methotrexate or other therapies. Next slide, please. Then we have the adverse events like the slower dose of increments. You can use the split dosing. You can make the evening dosing and switch over to the methotrexate, or you can start with the low dose of thiopurines. Next one. Then myelotoxicity, if it is there, I usually stop the drug. I don't venture to continue the drug. Next one, please. If you get hepatotoxicity, you reduce the dosage. But if it is having a severe toxicity, then stop the thiopurines and switch over to alternative drugs. Next one, please. Now, anti-TNF therapies have an increased risk of infections. These are population-based studies with a large population of 190,000 of IBD, 8,561 infections, and 674 opportunistic infections. The incidence rates are unadjusted are low. This is a French population study. And if you look at the viral infections or bacterial infections, viral infections are high. Opportunistic infections are higher. So anti-TNF monotherapy, there is a lesser risk of opportunistic infection and viral infections than with the thiopurine monotherapy. Next one. Malignancy, as I already alluded to, this is something which is a dreaded complication, and this comes with anti-TNF therapy. The black box warning has been given regarding the lymphomas and also the melanomas and other forms of lymphoma. Whenever we use the biologics, we have to definitely look into tuberculosis in the past or hepatitis. You screen them and then you see that they don't have any other infection, and then only you start the treatment. Next slide, please. Now coming to the comparison of incidence of serious and opportunistic infections according to treatment. Thiopurines compared with anti-TNF monotherapy. This slide is a busy slide. and it gives you the serious infections. Nevertheless, the infections are high whenever there is a combination compared to monotherapy. Next slide, please. This is a multivariate adjusted hazard ratios for opportunistic infections. The combinations are definitely having a higher risk compared to monotherapy. The hazard ratios are 4.3 and 4.7 with the mycobacterial and bacterial infections with thiopurines. TNF versus thiopurines, it is lesser 0.57 for viral, 2.38 for bacterial, and 1.2 for the fungal infections. Next slide, please. And this gives you the severe infections. Overall, the hazard ratios in combination, it is 2.11 compared to 1.7 with TNF alpha, either monotherapy versus thiopurine monotherapy. Next one, coming to reactivation of, next one please. Coming to reactivation in hepatitis B with the TNF alpha, I think this is one of the dreaded complications which can lead to death. So we should be very careful. Vedolizumab has no hepatitis B or hepatitis C reactivation in the post-marketing data. Next slide, please. Herpes zoster is one of the very important complications which has been observed with the Tofacitinib, which is an oral drug, and the hazard ratio has been quite high in this drug, which is 6.64 with the 10 milligrams, and 5 milligram it is 3.45, and 10 milligrams it is 4.25. Next slide, please. Reactivation of HBV with both Tofacitinib, the retrospective from Taiwan, 50% of HBV reactivation occurred in patients who are HBsAg positive with no antiviral treatment. So we have to give an antiviral prophylaxis 1 to 3 weeks prior to initiating any immunosuppressive therapy and continue the drug for a period of at least 6 months after the drug is withdrawn. Next slide, please. Venous thromboembolism. FDA warnings has occurred in the Tofacitinib, and upon FDA recommendation, this drug was compared to anti-TNF antagonists in the same clinical study. So all the physicians should consider the benefit and risk of starting an oral drug, and they should decide on the important effect such as herpes zoster. Next one, please.
So we have only 5 minutes for this session, please.
Okay, I'm going to close it now. The incidence rates of a post-frequency of serious adverse events, the overall, you can see pneumonia is quite high, and the least one is the abscess. Next slide, please. The safety of vedolizumab in all the 6 trials, it is a comparatively safe drug. Next one, please. There are lower rates of serious infections and adverse events in vedolizumab when compared to anti-TNF combinations in both ulcerative colitis as well as with CD. And this gives you the odds ratio is 0.37 and 0.29 of adverse events and other serious infections. Next one, please. The vedolizumab are less likely to experience safety events and serious infections in the new onset of therapy compared to those who are treated with vedolizumab when they have already received other TNF therapy. Next one. So in terms of safety of anti-TNF, it is a safe drug. Next one. The herpes zoster is there with the Tofacitinib. Next one. Vedolizumab, there is no increased risk of overall infections, slight increase in nasopharyngitis, CMV, and CDI. Next one. The Ustekinumab, there is no increased infections compared to placebo. And the solar registry, but there is only limited data. Next one. How do you rank the efficacy and the safety of the drug? So if you look at the safety and the safety pyramid, vedolizumab is a safe drug and it can be prescribed without much of concerns, but you have to monitor the patients very aggressively. Next one, please. Systemic adverse events with inflammatory bowel disease. The commonest is pneumonia and cellulitis. The anti-integrin molecules are unlikely to resist the result in systemic adverse events. Next one, please. So how to manage the safety of the drug and complications when you are on therapy? So managing active infections in patients with biologics, the strategy is the first one is either to stop treatment or reduce the dose. And this is the algorithm which has been described. Because we don't have much time, so I am not going to tell much on this slide. Next one. So can you go to the last slide? Next slide, please. So in conclusion, the moderate safety in patients who are on vedolizumab. The newer anti-TNF vedolizumab versus adalimumab, it is head-to-head, it is safe. There is the highest persistence of drug in this group. So I believe that vedolizumab is a good drug which can be given safely in patients with both ulcerative colitis as well as Crohn's disease. Thank you very much for the patient listening and the opportunity given.
Thank you for this excellent talk, sir. Since we're running short of time, we will conclude the session here. This session was sponsored by Takeda Pharmaceuticals. Over to Dr. Vishal sir for the next proceedings.